Good evening, everyone, and welcome and thank you for attending our Ahead of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Margie Leslie, and I'm one of the directors in the Cancer Institute who is responsible for screening and cancer outreach and screening. There are a few housekeeping items that we would like to review before we start. If you have joined via Zoom during the presentation, all participants can type questions into the chat or the Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants on Zoom are not able to speak during the conference, but again, we encourage feedback via the chat option. Tonight, we're excited to welcome Dr. James McCormick and Kyla Morphy, who will be speaking with you all about Will You Inherit Cancer, the latest in cancer genetics. As a professor of surgery, Drexel University College of Medicine, Dr. McCormick is a thought leader and international speaker with expertise in colon and rectal cancer, recurrent rectal cancer, inflammatory bowel disease, bowel reconstructive procedures, including sphincter preservation and J-pouch, complex pelvic surgery, laparoscopic surgery, robotic surgery, transanal endoscopic, and endoluminary surgery. He is the director of the multidisciplinary disease site for colorectal cancer for the Allegheny Health Network and the NAPRC certified AHNCI Rectal Cancer Center of Excellence. Dr. McCormick is a senior examiner for American Board of Colon and Rectal Surgery and has served on both the oral and written examination committees for the board. He is Commission on Cancer State Chair for the Southwestern Pennsylvania. He is an American College of Surgeons Governors and serves as the best practice work group for the college, in the best practice work for the college, and past president of the American College of Surgeons with Southwestern Pennsylvania chapter. He has served on Professional Outreach Committee, Standards Committee, and Self-Assessment Committee for the American Society of Colon and Rectal Surgery. He is vice president of the American Society of Colon and Rectal Surgery. He is an invited manuscript reviewer for diseases of colon and rectum, surgical endoscopy, World Journal of Colorectal Surgery, International Journal of Colorectal Disease. Dr. McCormick is an investigator for dozens of clinical trials, overseeing hundreds of thousands of dollars in research and grant funding, enrolling hundreds of patients. He has expertise in translational research, device trials, phase 1 and phase 2 pharmaceutical trial, 1, 2, and 3 pharmaceutical trials, randomized treatment trials, observation trials, and cooperative group. He is an Alliance certified surgeon and investigator for minimally invasive laparoscopic colorectal cancer and transanal surgery. Dr. McCormick has published over 90 peer-reviewed articles, book chapters, editorials, abstracts, and has given countless lectures and research presentations on the topic. After graduating from Lake Erie College of Osteopathic Medicine, Dr. McCormick completed a general surgery residency at Temple University at West Penn Hospital in Pittsburgh, Pennsylvania, where he received multiple awards for teaching, research, and clinical performance. He then completed a colorectal surgery residency at the University of Texas Southwestern Parkland Hospital in Dallas, Texas. He is board certified in both general and colorectal surgery. His clinical practice is focused on colon and rectal cancers, inflammatory bowel disease, and he practices at Allegheny Health Network, where he is faculty for general surgery residency, colorectal surgery residency, and is a certified proctor for the Da Vinci robotic surgery program. Kyla Morphy will also be presenting this evening. She is a practicing genetic counselor who has been practicing since 2004. Initially, she practiced at the University of Maryland, where she focused on pediatric cardiovascular genetics and adult cardiac genetics. She then joined Allegheny Health Network in 2007 as an oncology genetic counselor, and she has continued to help facilitate expanding the role of cancer genetic work and counseling in the Allegheny Health Network. She is currently the manager of our oncology genetic counseling program here at Allegheny Health Network, and Ms. Morphy has been working on expanding genetic counseling services in the network for oncology and has implemented multiple telehealth genetic sites to expand access for our patients. We would like to welcome Dr. McCormick and Ms. Morphy to present to us this evening. We'll be starting with Ms. Morphy.
Yes, thank you, Margie. So thank you all for joining us this evening. I hope this is a topic that everyone will find of interest. And I'm going to start off our talk today with some of the background information on cancer genetics and some of the genetics of breast cancer. Then Dr. McCormick is going to go through a lot more information on colorectal cancer and the genetics of colorectal cancer. So, just starting things off today, when we think about cancer in general, there are a lot of factors that are at play in developing cancer, and we'll never be able to kind of pinpoint one particular thing that is the answer. But a lot of it is just the interaction of these different factors together. And so, obviously, today, some of the ones that we'll focus a little bit more on are those, family history and genetic factors. And when we think of cancer in general, a number that's usually pretty surprising to people is that most cancer really is what we call sporadic or just happens by chance. So 75% of the time, cancer is that chance occurrence. About 15% of the time, cancer is what we call familial, which is a combination of maybe some of those, shared family factors, in combination with maybe some smaller genetic components that all have to be sort of, turned on in the same way in order to increase the risk for cancer in a family. And then the smallest part, and the part we're going to focus a little bit more on today, are those about 5 to 10% of cancers that actually are hereditary. And when we say hereditary, we're saying that they have an increased, risk based on genetic factors. There are a lot of different genes and a lot of different hereditary cancer syndromes that we've learned over the years, and especially in the last 30 to 40 years. So it's still newer in the world of cancer, but some of these conditions we do have a lot of information about. Some of the higher risk genes that both Dr. McCormick and I will focus on today are ones that some of you may have heard about, such as Lynch syndrome and BRC1 and 2. But then we also will touch on some of the newer moderate risk genes that maybe don't have as high of a risk, and some of the newer ones that we don't have a lot of information about right now, but probably will again in the next few years. So just an example of a family history that we typically think of when we think of more of that sporadic or chance occurrence of cancer. Uh, So this would be if we saw one individual in the family, diagnosed with a cancer at that, over the age of 50, or what we say like a little bit later age. That we don't really see other family members with cancer or the same type of cancers. And it's maybe one of the more common cancers like, breast cancer or colon cancer or prostate cancer. So a lot of times this is what a family history looks like. So I feel like we have a lot of patients that come in and go, oh, I was diagnosed, but I don't have any family history. And I'm usually the one being like, well, that's actually more common than not. That familial group was that second group that I mentioned. And this one, I like to think about all the factors are pretty much playing a similar role. So we have, some genetics, some lifestyle, some diet, some environment. And then there's always that chance factor there. But all those factors, none of them are really overlying the other ones. With hereditary cancer, that genetic component is much larger. And so I always, do point out that just because you have one of these genetic mutations, it doesn't mean you're going to develop cancer. It is just a risk factor that we can pinpoint a little bit better than even some of the other risk factors. So it's just giving us a little bit more information going forward to say, we know this individual has a higher risk based on this genetic marker. Most of these genetic conditions that we think about when we think about cancer are passed through families in what we call a dominant manner. Dominant just, autosomal dominant just means that men and women can both equally carry these genetic changes. And dominant means that it only requires, one mutation in order to have that higher risk for cancer. So you don't need to inherit something from mom and from dad for most of these conditions, except for one that Dr. McCormick will talk about later. But for the most part, you just need to inherit it from mom or dad in order to have that increased risk for cancer. Because most of these conditions that we've discovered thus far are autosomal and are not on like the X and Y chromosomes, we care about mom and dad's history equally. So even if we're talking about breast cancer, we care just as much about dad's side of the family because those genes can pass through the paternal side as well. This is an example of one of the families that if we looked at it, we might go, okay, there's a pretty high likelihood of something being hereditary here. So in this family, you do see more breast cancer or cancer in general than you would expect to see just by that like sporadic or chance occurrence. Um, and then we're also seeing it at a little bit later age or younger ages. So in the 30s and then 40s, and seeing that like every generation pattern where it looks like it's being passed from one generation to the next. Um, So just looking at this family history is one that would make us more concerned that there could possibly be an underlying genetic cause in this family. So, when people come in to see us in genetics, how do we assess for hereditary cancer? And that is a lot of what I do in my role here, is just seeing if this family is one that could have one of those hereditary markers. Um, the first, one of the things we're looking at is just the ages people are diagnosed, especially for some of those more common cancers like breast and colon cancer. Um, if they're diagnosed at a more typical age, like in the 60s and 70s, it's a little less likely to be something that might be hereditary, maybe falling more in that chance sporadic category. But if we're seeing people diagnosed younger, and in age of 50 is usually our cutoff that we use, that's when we start to consider maybe one of those possible genetic causes. The other thing we look at is if there's rare cancers in the family. So ovarian cancer, male breast cancer, pancreatic cancer, um, very specific type of stomach cancer called diffuse stomach cancer. All of those are rare, and even if we don't see other family members with those types of cancer, them in themselves is enough to consider a possible hereditary cause. And then if we see multiple family members. So obviously, if we're starting to see that pattern of multiple family members with especially the same type of cancer or cancers that can be linked together with any particular gene that we know of, it does make us, consider one of those hereditary markers. And then if someone's had, more than one cancer type, so more than one cancer type themselves. So if someone's had like, breast cancer on one breast and then a separate primary breast cancer on the other side, or like colon and uterine cancer, or like breast and ovarian cancer, where we're going, okay, this is a little less common to see two separate cancers. Maybe there's some underlying genetic cause here. Um, just because those are some things that we look at doesn't mean that there aren't other things that we consider as well. We can still have some suspicion for hereditary causes, even for different cancer types or different patterns. But the ones that are, more suspicious for a possible hereditary cause are those, like the early onset colon cancer, so like age 50 and less. The early onset breast cancer, 50 and less, especially if there's any family history of those cancers. Early onset uterine cancer. So again, sort of 50 or less, ovarian cancer. But then there are cancers that we know maybe have more environmental factors involved with them, or less likely to be hereditary, more likely to be sporadic, or that there is some other underlying cause that's not genetic. Um, so some of those cancers would be like, lung cancer. We do know of, exposures that are related to that. Cervical cancers, we know of different viruses that are related to that sometimes. Head and neck cancers. So those, even if we see them in the family, may be less likely to be hereditary. We don't know many, genetic markers for them, uh, but might be more, other exposures that are shared within the family. And then if there's, breast or colon cancer over the age of 50 and no additional family history of those cancers or other cancers, again, maybe more likely to be sporadic than hereditary. And then hematological cancers. So those are like the leukemias, lymphomas, multiple myelomas. At this point, we don't know a lot of genetic markers for those. There may be more in the future that we've discovered, but right now they're not ones that we have a strong, like hereditary understanding for. With that being said, we do even have some additional criteria that we can use to evaluate a family. And sometimes that information can give us a better idea as to whether or not there could be something genetic there as well. And one of the ones that I just wanted to point out, because I know it will come up again later, is the Amsterdam 2 criteria. So these are criteria that were developed by Henry Lynch, who is the father of cancer genetics, as we call him. And this was developed many, many years ago. So in the late 80s, early 90s. And he came up with criteria that we could use to, give a family a clinical diagnosis of Lynch syndrome, which is a hereditary colon cancer syndrome. And so when a family presents, we take these very detailed family histories, and then we go through the family history to see if they meet these criteria. We always call them the 3-2-1 rule. It makes it really easy to remember. It's, having three affected family members. So three members in a family that all have a Lynch syndrome related cancer, which we will talk about in a little bit. Two generations. So that's, either grandparents, eh, mom, aunts, uncles, or the person we're looking at. So at least two generation. Um, one of them has to be a direct relative of the other one, and one person has to be under the age of 50. So they use this criteria to evaluate the likelihood that we would find, a genetic marker for colon cancer in a family. But anyone who meets these criteria, we definitely would want to consider, looking at them for genetic testing as well. So how does genetic counseling and testing work? Part of my job is that I see patients who have been referred to us because they either have that family history of cancer or a personal history, which is a little bit more suspicious for a possible hereditary marker. And we will collect, detailed family histories on these individuals, and go through their medical history. And then looking at their family history, we'll determine whether or not it looks like they, have a higher likelihood of falling into that hereditary category. And if it does look like, there could be a hereditary marker in their family, and that genetic testing might be helpful for them, we'll coordinate getting the sample for those patients, and then we'll send it to the lab that would analyze the testing, and then call the patient with results, and then go through, what those results mean for them and their family. And I know we've been talking a bit about genetics and sort of what this is, and I just wanted to go a quick overview before we talk a little bit more about, what that genetic testing piece is. Back to our high school biology lectures, everyone probably remembers, in all the cells of our bodies, we have our chromosomes. We have 23 pairs of chromosomes, one copy of every chromosome from mom, one from dad. And amongst these chromosomes, we have like 20 to 30,000 different genes. So these genes that we've been talking about are all ones that their roles in our body are to prevent cancer. They're things like tumor suppressor genes or mismatch repair genes, that should be there and working, and they help prevent errors in our cells from becoming cancer cells. So when we do genetic testing, what we're actually doing is looking at that DNA code. So we're taking it, sort of one step further and looking at the DNA code of that particular gene. And I always tell people it's pretty much like we're spell checking genes. At this point, we've decided what we're looking at based on the family history, and we are going to zoom in on that particular gene and read through the DNA code. If the DNA code's spelled correctly, then that gene, looks like it's working, it's doing its job. If it's not spelled correctly, that's when we say that there's a mutation in that gene, and that mutation can be related to a higher risk for cancer. So when we do genetic testing, a big question we always get is who are you going to test? Who's the best person to test in the family? And actually, because we don't know all the genetic causes for cancer, the best person to test is going to be someone who is most likely to have a mutation. So be the person that fits that picture of maybe that hereditary possibility the most. So someone diagnosed with younger cancer, somebody with a rarer cancer, because if we're going to be able to find in the family, it's going to be that individual. So I always kind of use this picture. Like if you're trying to figure out why this one tree has yellow apples, and the other one doesn't, are you going to test the yellow apple on that tree or the red apples? Like you're going to look at the yellow apple. You're going to try to figure out why there's that yellow apple there. Same situation with genetic testing. We want to test the person that stands out the most in the family. Obviously, not always a possibility, so we can always test other individuals. It just might change how we interpret the results a little bit. So when we do testing, just like everything else in medicine, there are three different possible results we can get. The positive result means we did find a genetic mutation in that individual. And then we would, have a discussion about what that means for that person and their family. Negative means that there were no mutations that we found, at least for the testing that we were able to do at this point. We've come a long way with genetics over the last, 40 years, but we know that there's still a long way to go in, understanding some of these other changes that we haven't discovered yet. So even if it's negative, we still, resort back to the family history to use that as a guide for the family and that patient. And then, of course, we can get that, gray zone result, or in genetics, we call it a variant of uncertain significance, which is just sort of our fancy way to say, found something in the genetic code, but we don't know what it means at this very moment. Um, the big difference with genetics is that we don't need to redo the testing. That's not going to clarify those gray zone results because your genetic code isn't changing. It's been like that since birth. Really, science just needs to kind of catch up to figure out exactly what that change means. Because there is a lot of normal variation in our DNA. We're not all exactly the same, and we're not supposed to be. So if we get an uncertain result, we do kind of resort back to treating it like a negative result and just doing things based on the family history. So why do people choose to do genetic testing? So we've kind of gone through the process. We decide this family, might benefit from genetic testing. Why would someone actually do it? And we have quite a few different reasons now. One is that it can change treatments for individuals, whether it's going to help give them information about, surgical planning, or even chemotherapy selection now. So we've come, a long way even in how we can treat individuals based on their genetic makeup. Um, and information for the future. So, more information about what cancers we might need to be more vigilant about going forward. Is there some proactive, screening or even risk reducing surgeries that we should think about? And then, obviously, a big one is for family members. I feel like a lot of patients that I have seen that have their own personal history of cancer, they tend to be thinking a lot about their family members and what they can, do or help those family members know in order to, be proactive going forward for the family and hopefully catch things early or prevent things if we can. And then, of course, the last thing is why did this happen? Which unfortunately, I'm not always able to answer when we do genetic testing. I wish we had an answer for that for everybody. And someday we might get a little bit better at knowing why cancer happens. But for some people, they're almost hoping we can find an answer, especially if there is a strong family history to go, why is this happening in my family? Is there something, is there a genetic marker here that's making the risk higher? And then the flip side. So, why do people not choose to test? And when people come in to talk about genetic testing, we give them all the information, and they can decide, like, is this something I want to know or not? So, one of the reasons, or some of the reasons people don't test is, they're overwhelmed with other information right now. They're going through treatment, they have lots of appointments, and sometimes just feel like another piece of information telling them that they might have a higher risk for a second or third cancer is just not something that's, good for their mental well-being at that moment. Um, and, discrimination and privacy is another big concern that people have. We'll talk about that in a second as well. Cost also is a concern for a lot of people, although that has become much, much better over the years. Most of the people will owe less than $250 for genetic testing. So it's definitely come down a lot just with our, increases in technology. They were able to make things less expensive than they were beforehand. And then some people don't test because of family members. They're worried about their family members being discriminated against if they know that they have a genetic mutation, or they're worried that they could have passed something on to their family members. And parental guilt is a really strong emotion, so sometimes that's something that that person feels like they just wouldn't want to know that. And we understand everybody is different and their family dynamics are different, so doing genetic testing isn't going to be the option for everyone. And how genetic testing, like I mentioned, has changed a lot. So we have come a long way over the years. Prior to 2015, we did not test for as many genes as we do now. Now we have over 100 different cancer genetic genes that we can look at depending on what indications we see. Prior to that, we most of our testing was focused on BRCA1 and 2, and then Lynch syndrome. And actually, a fact most people probably don't know, but Lynch syndrome was identified before the BRCA1 and 2 genes. It just didn't quite get as much press as BRCA1 and 2. Lynch syndrome was actually first described in the 60s by Henry Lynch. And then he developed those criteria, the Amsterdam criteria, in the late 80s and started using it in the 90s in research studies. So that actually has been around for a long time. But over time, we have gotten to the point that we do multi-gene panels, so looking at multiple genes at the same time. As our technology got better and we can test more, we're able to do a lot more for even less cost to insurance and patients. And like I mentioned a second ago, cost also has decreased substantially over the years. And most insurances cover it now. We had trouble getting things covered back in the day, but even now, Medicaid plans have criteria for coverage, which wasn't an option 10 years ago. And then the frequency of cancer screenings and the type of cancer screenings for a particular gene mutation, that gets updated frequently. So, I mean, every few months, I feel like we are still learning more about these genes and what we should do with them. So we always do try to keep on top of things for patients just to keep them updated when new recommendations may present regarding whatever we had discovered in their family. So, privacy and discrimination, I know this is a big concern for a lot of people, so I always like to touch on it. Genetic testing is a medical test, so it is going to end up in the electronic medical records, just like any other medical test. So it is something that would be viewable by, other providers who have access to that medical record. But at the same point, it is protected like any other medical test. And actually even has an extra level of protection for genetics. So the Genetic Information Non-Discrimination Act, we call it GINA for short, that was actually signed into law in 2008. They started that process in 1996. So it's been a long time that this has been on the radar. And it does prohibit against discrimination with regards to health insurance for group plans over 15 people and for employment. So there are a couple little stipulators there on the size of the plan and what it covers, but a lot of people will fall into that category. And then it also, the things it doesn't cover are things that I always say, are those bought into insurances like life insurance and long-term care. So those are still things that can ask anything in your medical records. So they can ask about genetic testing. And we do occasionally have individuals who will get their, life insurance before doing genetic testing and lock in a term plan. So there are a lot of options as well, and things that we all talk about during our appointments when we do, sit down to go through all of this. Another thing that I feel like comes up a lot, so I just wanted to touch on quick because it is all the rage these days, is the direct-to-consumer testing. A lot of people have probably seen the at-home saliva collection kits where you can find out your ancestry and do some genetic testing. And some of the genetic testing actually includes some of these genes that we're talking about, like BRCA1 and 2. I was like, all the labs that, really are the direct to consumer that you don't need to have ordered by a physician are ones that they do recommend that testing is confirmed at a independent genetics lab prior to acting on that information. So they're not supposed to be used for clinical treatment. So always like, if you did that kind of testing, we were happy to see you again, even if they did find something to, confirm and kind of go through all that information. And the opposite, if it was negative, we still would want to repeat that testing at a independent genetics lab. And for different reasons, technology is not meant to be as specific as the typical technology that's used. And then the testing they do is not comprehensive. So, when I was showing the gene and we were reading through the whole entire DNA code, that's not what these labs are doing. They're doing very like targeted testing of particular changes that are more common. But definitely, when we look at BRCA1 and 2, 23andMe now looks at like 44 different common mutations. Well, we have seen thousands and thousands of them, and a lot of them are family specific. So, if you had 23andMe and it was negative for BRCA1 and 2, I definitely have had individuals come in and we find mutations in those genes um, that are in a different area that was tested prior. So definitely just, if you did home testing, we are happy to see you again just to do more detailed testing. Um, So when we do genetic testing, the part of what we wanted to talk about today was, how can this information inform treatment? And it really can affect quite a few different categories of treatment. Um, which the more we learn, the more I feel like we're expanding some of these categories even. But the big things that it affects in terms of treatment are, surgical management and recurrence risks, chemotherapy selections and prognosis, and then other cancer risks that we might need to put on the radar for that individual. So when we think about, breast cancer, just like colon cancer, about 5 to 10% of breast cancers actually have a hereditary component to them. The biggest genes that contribute are the ones that we've known about the longest, which kind of makes sense. They were easier to discover because those families were um, a little bit more noticeable in terms of their patterns. So BRCA1 and 2 are still the biggest player when it comes to hereditary breast cancer. But we do have other genes that we're looking at now as well. Those are the ones that we just started testing for like after 2015. And some of those newer genes are listed here. Promise there's no tests at the end. You don't need to know these. But the biggest thing that I like to point out is just that if someone had just BRC1 and 2, prior to that 2015 when we weren't doing panels, there are, insurance guidelines and clinical guidelines for quite a few other genes now as well. So definitely those individuals, it may warrant some additional testing for them just to cover some of these newer genes that weren't evaluated back in 2015. Um, so for BRC 1 and 2, the guidelines that we look at for all those newer genes are actually they're pretty much the same as the ones that we use for BRC 1 and 2. So when thinking about what individuals to refer to genetics or what patients should be seen, um, it's anybody with a breast or anybody with ovarian cancer, any age, males with breast cancer, any male or female with pancreatic cancer, regardless of family history, um, any female who's had triple negative breast cancer, regardless of age, any male with metastatic prostate cancer, and then if there's a woman with multiple primary cancers, so whether it's bilateral or in the same breast. But really, the number we look at is if there's been like more than 3 cases of breast cancer in a family or any kind of combination of these cancer types that can be related. Um, and then anybody with breast cancer 50 or younger. And I feel like a lot of people are probably familiar with some of the hereditary breast and ovarian cancer risks. Obviously, the biggest risk is breast cancer for individuals who have a, BRC1 or 2 gene. But then there is an increased risk of a second breast cancer as well, which is why this information can be helpful in surgical planning and in treatment. Um, Also, ovarian cancer is the bigger risk factor for women, and then men have that higher risk for male breast cancer, I'll bet lower than females, and more aggressive prostate cancer, which then might change how we screen individuals. And pancreatic is something that we can see in both men and women that have BRC1 or 2 mutations. So with BRCA1 and 2 management, it really falls in also a couple different categories. One is just doing an increased screening based on, the higher risk for the cancers that we know are related to those genes. Chemo prevention like tamoxifen or raloxifene, or even oral contraceptives, all things that can reduce some of those cancer risks that we know can be related to BRCA1 and 2. Um, Surgical risk reduction. So, things like considering bilateral mastectomies to reduce the risk, or oophorectomies, and then systemic treatments, so even chemotherapy selections for individuals. So when individuals, find out that they have a BRC1 or 2 mutation, these are all the numbers that we talk through with them. What their options are, and how much that can reduce their risk, just to help them make decisions on what might be, best for them. In terms of, screening for individuals who know that they have a BRC1 or 2 mutation, we tend to start screening, younger and doing it more often. So for, breast cancer risks, we start screening at 25 and usually do breast MRIs between 25 and 30. And then at 30, also incorporate the mammograms as well. So individuals are getting, two different screening types and starting much younger than the general population. Um, for ovarian cancer, we talk about some of the options for screening. Unfortunately, we're not, as good at screening for ovarian cancer yet, like we are for breast cancer. Hopefully, that's another development that will be coming down the road. But things that they will talk about would be like, a transvaginal ultrasound to look at the ovaries, and maybe a CA-125 test. For the ovaries, because our screening isn't as robust as it is for breast cancer, there is more so a recommendation to consider having ovaries removed at some point. And the timing of that is really dependent on, what gene we actually find a mutation in and when that risk does start to increase. For breast cancer, there is the option of, bilateral mastectomies or risk-reducing mastectomies. That one is a little less of a recommendation to consider and more of just an option because we do have a good screen for breast cancer. And the goal is to pick things up early. For men with BRC mutations, we do recommend some breast screening for them as well, and starting around 35, but mainly clinical breast exams, with the option of mammograms. And then the prostate screening, starting at a little bit younger, especially for those BRCA2 carriers. Pancreatic screening isn't typically recommended for BRC1 and 2 carriers unless there is a family history of pancreatic cancer that we know of. And then melanoma can be related to those two genes as well. So they do recommend, a derm exam. Just gonna get us moving a little bit through some of these things. So the one thing that I, wanted to show, just because I feel like it's interesting to see how much we've learned since 2015. You'll recognize a few of these genes on here. So you can see the BRCA1 and the BRCA2 gene, but this is a tumor suppressor pathway in our body. And a lot of those other genes that are in red are other genes that now we can test for when we're looking at hereditary breast cancers, which kind of makes sense. They are in the same tumor pathway, so it makes sense they probably have a similar presentation. So these are all genes that are now part of the panels that we do. And they may not have as high of a risk for breast cancer as BRCA1 and 2, but still have enough that we would be at least doing that increased screening. And there might be other cancers that we can see with them as well that we need to put on the radar that weren't necessarily on the radar. The last sort of part that we talked about in that pie chart of what can change is just even treatment. So sometimes now we're changing our treatment or chemotherapy selection based on genetic status. And that's been also just in the last 10 or so years that we've really started to do this more often. And there is a lot of overlap between the genetic changes that we find in a tumor cell and some of those like born with genetic changes, but they are not exactly overlapping perfectly. So sometimes we will see someone that has, like, say, a BRC1 or 2 mutation that, that is hereditary, but then when we look at their tumor, we may not see that mutation because it is not a perfect overlap. But in terms of treatments, there are different chemotherapies that may be selected for individuals that do have those like BRC1 or 2 mutations. And so I am going to pass it over to Dr. McCormick to kind of take over with some of the colorectal cancer syndromes.
Well, thank you very much, Kyler. That was a great talk. I learned a lot myself, so I appreciate you sharing that with us. We send a lot of patients to Kyla and her colleagues, but I don't get to see what happens there too often. So I really appreciate you sharing that.
Oh, good.
So I'm going to get a couple of terms out of the way. Kyla went through quite a few things in terms of the terminology used in their practices. But in the general population, when you're out there reading papers or talking to people about genetics, there's a couple of terms that I think are a little bit confusing to people. So to help people understand better, what these things mean, I just wanted to go over a couple things. So genetics versus genomics. So genetics is what Kyla's been talking about. Genetics is the stuff that you inherited from your parents. These genes that you inherit dictate your basic traits, and they're passed down from generation to generation. Genomics, and you may hear of someone saying, my doctor sent my cancer off for genetic testing. If they sent your cancer off for genetic testing, they were actually testing the genomics of that cancer. This is the study of that particular cell or that particular part of the organ that's involved. And this is based on the phenotype. So there's an interaction in your body that occurs between the genes that you've inherited and various environmental factors that actually make the genomics, whatever expression of those genes is in genomics. So there's a sports phrase that says you can't beat genetics. So the 7'4" basketball player has an advantage, right? But genomics, on the other hand, we have a chance because we can impact perhaps some of these environmental factors that may impact gene expression. So important to understand the difference. Next slide, please. Thanks, Kyla. I
Sorry.
appreciate you trying to stay ahead of me. So epigenetics is another term, again, has the word genetics in it, but can be very confusing. Epigenetics are those environmental factors, okay? A gene, which can be a gene that you've inherited, which Kyla has been talking about, or a gene that has been mutated within your body, in the case of colon cancer, within your colon. That gene determines what protein is made or not made and whether it works well. Gene expression is when or how often, if that protein is made. Epigenetics can affect whether that gene is ever expressed in your body. So an environmental factor can actually turn a gene on or turn a gene off. And that is very important to understand how we as individuals and how we interact with our environment and live our lives, how we may be affecting how genes are expressed in our body and how potentially cancer develops or grows. Now you can go to the next slide. And then when we talk about mutations within individuals, it's important to understand the difference between a germline mutation and a somatic mutation. It's kind of the same thing that I've been talking about, but a germline mutation are the things that Kyla's been talking about. Those are the inherited passed down things that are in your genes. That's part of your genetic code. The somatic mutation is the mutation that occurs within your organ throughout your lifetime. And it happened after conception. So it can happen in utero or it can happen throughout your life. It's not passed down to other people, but those cells can go on to develop different traits, including colon cancer. This is how that happens in colon cancer. And this is why colon cancer screening works so well. There are precursors in colon cancer to the development of cancer called polyps. And in order for the polyps to occur, there has to be a change in the way that normal colon cell is expressing itself. And that requires a mutation. So when someone has a mutation in a normal colon cell, it becomes a polyp. And we can go in with a colonoscopy and remove that polyp and nip that whole process in the bud. Alternatively, if that abnormal cell is able to accumulate additional mutations, that can come in to become a colon cancer. So that is how cells will accumulate mutations throughout your life over time. And when you have, in colon cancer anyway, 2 or more mutations, it can become, a problem in terms of cancer. Go to the next slide, please. Thanks. So if you click that video, people can see a polypectomy being performed there on the lower right-hand side of the screen. So the polyp is up here on the upper right-hand side of your screen. That's just a polyp, and we can take that out, and that will stop the cancer, which is on the left-hand side of the screen, from from forming. So you can see there's a big difference between even the way they look. And how we do that is depicted in this video. We take this little lasso in the colonoscopy there, and we snare around that polyp right at its base, just like you would, trim a tree, and we cut that right off. And once it's cut off, it can no longer accumulate additional mutations and can no longer grow and become that cancer that we just talked about. So this is why the recommendation is for colonoscopies beginning at age 45 in all people, regardless of your genetic, regardless of your anything else. If you have genetic risk factors, which we're talking about here today, or family history, you may have to have one earlier, but 45 is the general population. You go to the next slide, please. So let's talk about the colorectal cancer syndromes. There's two main categories of colorectal cancer syndromes. There's those that have those polyps before the cancers develop, and there are those that don't have those polyps first. And that depends on where that gene is in that little sequence that I talked about. So the three main polyposis syndromes are FAP, which is familial adenomatous polyposis syndrome. There's an attenuated version of that, which is AFAP. And then there's MYH-associated polyposis syndrome, which is Kyla referred to this earlier. This is that one that is not autosomal dominant, it's recessive, and it actually happens among siblings instead of from mom to dad or mom to child or dad to child. And then there's the Lynch syndrome, which is the most widely known and the oldest known genetic cancer risk that I'm aware of. And there, unfortunately, is no polyposis in that. So there's no precursor lesions that we can nip in the bud. So those patients are a little higher risk than the general population. You go to the next slide. So a little bit of, this is a little detailed slide. I'm going to skip through some of the details, but the bottom line is that sporadic tumors, as Kyla has told you, occur in about 85 to 90% of colon cancers are sporadic. They develop within your body after conception, and you had no genetic predisposition to that we know of. The other three, polyposis syndrome, Lynch syndrome, FAP, and MYH polyposis, those are the kind that are genetically handed down. And how they're handed down is how Kyla goes about finding where those mutations are in your genetic makeup that puts you halfway down the road to developing colon cancer before you're even born. And that's the problem. Next slide, please. And this is how that works. So I'd mentioned that there's the FAP and its attenuated brother. There's the Lynch syndrome, and then there's the MAP, which is the autosomal recessive genetic mutation. They affect that polyposis syndrome to cancer syndrome, that whole timeline that I talked about earlier, at different spots. So the FAP affects the left side of that whole process and makes a bunch of polyps. Again, you have a bunch of polyps, so you're already a third of the way to developing cancer. Those patients have a very high risk of developing cancer at a very young age. The Lynch syndrome is on the other side of the equation. They skip past the polyps themselves, and they actually just become a cancer off the bat. That mutation that they have puts them in a big trouble at an early age as well, but they skip the polyp phase. And MYH can kind of mask as any of them. So it's a little bit harder to figure out how that pattern is going to develop in somebody. We can go to the next slide, please. So again, a little bit of detail about FAP. There's a specific gene called APC, which is a tumor suppressor gene. Kyla mentioned that earlier in her talk. And this can be detected in persons, generally at young age. Hopefully they already know that their family has this, because by the time they develop symptoms, unfortunately, there's a high risk that they've already had a cancer develop in their 20s, which is a pretty young age. It's a very high penetrance, and it's autosomal dominant. So again, it will go down, and if it's there, if it's present, it will work. It will have its effect. There's an attenuated version, as I mentioned, where the patients don't develop quite as many polyps, and we're not quite sure why that occurs in certain patients. Next slide, please. So the problem with FAP is that the adenomas appear when they're teenagers or in their 20s. And those are the polyps, and there's a bunch of polyps, and the patients may get symptoms, mucus or bloody bowel movements, or they may not. But by the time symptoms appear, they may already have developed cancer. So this is a big problem. So we have to catch these people based on their family history when they're young teenagers and start screening for that development of those polyps and prepare them literally, next slide, please, to have their colons removed before their age 25 is the recommendation. So the symptoms, as I mentioned, bleeding, diarrhea, and again, if you wait for symptoms to develop, they'll already have cancer in their 20s. Next slide, please. There are some things that go along with FAP. So if we diagnose someone with FAP, you're gonna talk to Kyla. She's gonna sit down with you and say you're at risk for other types of tumors as well. And these are some listings. I'm not gonna get too detailed about that. There's one here called congenital hypertrophic retinal pigment epithelialization called CHIRPY, where people can actually be diagnosed with FAP by getting their eyes checked. So if they have this, when the ophthalmologist or the optometrist looks in their eye, they need to be sent to Kyla so they can get genetic testing and we can find this thing before the colon cancer develops. So that's kind of the opposite way around. Next slide, please. Desmoid tumors are a big problem for people with FAP. There are certain people with certain specific mutations in that gene that are going to develop more of these desmoid tumors. They're technically benign, but they grow big and they get in the way and they can actually cause you to have death from these abdominal lesions because you can't eat anymore. And that's a big problem. So we do want to detect these people so that we can potentially give them some medications to try to mitigate that risk. Next slide, please. We can skip. This is too much detail we're running out of time. I don't want to spend too much time on that. So the treatment of FAP or the management of FAP is quite straightforward. If someone has a family history, they have the gene, they get tested by Kyla, and they also carry the gene as an individual patient, then at age 12, they begin with colonoscopies. So you can imagine how difficult this is to start to imagine, having this problem at age 12. They're getting prepared at that time for an eventual colectomy. They have to have their colon taken out, usually in their early 20s, so that they do not develop that cancer. And you certainly want to do it before they develop symptoms. The other thing that they can get is thyroid cancer and cancers in their upper gastrointestinal tract. And that's why they also have to get screened by what we call an EGD, which is a scope that goes down from the top into your stomach, and an ultrasound of the thyroid, again, starting at a very young age. Next slide, please. What we do as surgeons when we see someone with FAP, if we take out your colon to remove the at-risk mucosa that can develop into a cancer, which is the proper treatment, just as someone with BRC mutation may get a bilateral prophylactic mastectomy, we take out the colon again to remove the at-risk tissue. How does their gut work, right? That's the question people would ask. Well, with the mastectomy, obviously, those can be reconstructed by a plastic surgeon and often are. It's a choice of the individual, but it's often the case. We can do the same thing with the colon. We reconstruct basically a rectum out of your small intestine, which is at much lower risk of developing the cancer. And people can actually live their lives in a relatively normal way without having to worry about having things like a colostomy bag. So this is a very important discussion that we have to have with patients, young, healthy people, having this operation in the prime, basically the prime of their social life, and they're trying to live their life, being able to offer them this reconstruction and not have to have concern about a bag is critically important and helpful. Makes it so that we're able to actually convince them to do it. Here's a video that if it's going to run, and this just shows how we're able to do these operations. I'm not going to spend a lot of time on this, but I'm a surgeon. I have to kind of show and tell. So for the people, you can see we're using a robot in this case. So it's a minimally invasive approach, very highly technically adaptable instrumentation. We're actually actively, in this particular case, you can see we're pushing down those structures, and those structures are actually nerves that help people to have function of their bowels and their bladder. And if we don't preserve them, then they can have trouble with that. So this equipment that we use, this technology that we use, is very helpful in allowing us to help people have a better functional result when we're done. So I just wanted to put that in there for people who might be curious of what things look like when we're operating. Next slide, please. So attenuated FAP, as I mentioned, it's FAP's little brother. For some reason, they don't fully express the full FAP, and so they have a smaller number of polyps, and they still have an increased colorectal cancer risk. Instead of being 100%, which is FAP's near 100% if they live to be into their 30s, for attenuated FAP, it's about 65%. And so we still probably, in many cases, are going to recommend prophylactic colon surgery, just maybe at a little later age. Next slide, please. The other polyposis syndrome that I discussed that looks a lot like attenuated FAP, not millions of polyps or thousands of polyps like FAP itself, but maybe tens or hundreds of polyps, is called MYH-associated polyposis syndrome. This is that autosomal recessive inherited mutation. And so somebody's brothers and sisters would have it and not necessarily their parents. And that's how we figure that out. If someone has multiple polyps, tens or hundreds of polyps, they should be tested for this. We have to test them for that. You can go to the next slide, please, so that we can know that they're at risk for this, and we can know that their siblings are at risk for this. And the risk of developing colorectal cancer is 200 to 300-fold increase. So it's something, again, that we will recommend at least a total colectomy in many of these patients prophylactically if they have both mutations missing on both genes. Next slide, please. So if you have cancer in a patient with a bunch of polyps, we're going to test them for MAP. If they have MAP, again, we're going to prophylactically remove the remainder of the colon, not just the part of the colon that has the cancer in it. Unfortunately, this is a lot harder to detect, so it does take us additional, we're often seeing patients who've already developed the cancer by the time that we find this. So that's why we're making these decisions, unfortunately, backtracking, because it's harder to find these autosomal recessive genes than autosomal dominant ones, which tend to be easier to map out when Kyla does the tree of the family history. Next slide, please. So Lynch syndrome is the big one. Lynch syndrome accounts for up to 10% of colorectal cancers statistically. It may be that it's more than that because, as Kyla mentioned, we know of 4 or 5 or 6 genes that cause Lynch syndrome, but there may be dozens that we just haven't figured out yet. Again, it's not autosomal dominant, meaning that if you have one of the genes passed down from a family member, you're likely to have this Lynch syndrome. And they skip through that polyp phase and go right to cancer. So although screening colonoscopy is part of the equation, it's much more frequent than the average population. Average population get a colonoscopy every 10 years because it takes that long for that polyp to form and then become a cancer. It takes a long time. In a Lynch syndrome patient, it's attenuated. It's a very short period of time. And so we want to get them screened much more frequently. Next page, next slide, please. So these are a few of the genes that Kyla would be testing you for, that there are probably others that we just don't know. So if someone has that family history that's strong and we don't find these genes, we kind of assume that they have Lynch syndrome anyway and may treat them that way. Next slide, please. So there are associated cancers, endometrial and ovarian cancers. So our female patients will go off, we'll diagnose them with Lynch syndrome. We will send them off for screening for those as well on a regular basis. Prostate in males, urinary cancers. So we may test people's urine on a regular basis, or they may go see a urologist and have a cystoscopy done. And pancreas cancer, you're probably going to be getting screening for your colon cancer or endometrial cancer. But if we see anything on the pancreas on those screenings, we're going to be very attuned into that. There's some other syndromes that are associated with skin lesions or brain tumors. Those are rare, more rare syndromes, and those can be picked up as well through the screening process. Next page, next slide, please. So this is a little bit of a summary of Lynch syndrome cancer risk. The average person has a risk of 5 or 6% of developing colon cancer in their life. A Lynch syndrome patient, it's up to 80%. Totally different, right? Endometrial cancer, same thing. 3% risk in the general population, up to 60% in patients with Lynch. And when we look at stomach and ovary, those are rare cancers to begin with, very rare cancers to begin with, and they start to creep up into the teens and 20s in these patients with Lynch syndrome. So we really need to be aware of when these patients have Lynch syndrome so that we can hop on these cancers early and save their life. Next slide, please. This is a busy slide, but this is something called the NCCN guidelines for Lynch syndrome. If you want a reliable source for information, you can go to the NCCN, the website. Just type in NCCN in Google and you can go there. It won't give you this exact thing. It will give you a picture that is more attuned to the general population and not, this is the one that the doctors and the geneticists might pull up. You would have one that was for patients, and it would give you all the information you may want about what you might expect for a patient with Lynch syndrome in terms of the standards of care. Next slide, please. And here's the basic stuff. Again, similar to the previous slide, what do we do when someone has a diagnosis of Lynch syndrome? So either you have that strong family history and you know you have Lynch syndrome before you get a cancer, or you develop that cancer at a young age and we decide that you have Lynch syndrome. What are the things that we're going to look for? We're going to get a colonoscopy every 1 to 2 years. Again, general population, it's 10 years. You skip the polyps when you have Lynch syndrome, so we got to do it much more frequently. This starts in your 20s. Or if your family member had their cancer discovered in their 20s, it may start in your teens. So we have to be very aware of that. You're going to get endometrial and ovarian cancer screening, which is generally with ultrasounds and perhaps blood tests, again, every 1 to 2 years. And you're going to have your upper gastrointestinal tract looked at with that EGD scope that I spoke about every 3 to 5 years, because you can develop adenomas and cancers there as well. We consider, depending on the specifics of the patient's genetic makeup, we may consider screening for urinary cancers as well. Next slide, please. So there's something interesting about Lynch syndrome tumors. They're called MSI high tumors. MSI is called microsatellite instability, and it's something that we can see when we look at the makeup of those cancer cells, the way that they are expressing certain genes or not expressing certain genes. So when the pathologist tells us that the patient has an MSI high tumor, they have a better prognosis than the general population, which is good, right? You still have cancer, but you have a better cancer than might have been the case otherwise. There's a couple of treatment things that we need to take into account for MSI high tumors too. The standard chemotherapy for regular colon cancer patients is something called 5-FU. That doesn't work so well in MSI high tumors. So we have to change our chemotherapy regimens for patients with MSI high tumors, which is almost all Lynch syndrome patients. And the other thing that has to be taken into account is that, next slide, please, is that MSI high tumors respond very well to immunotherapy. And some people may have read this article in the paper a few years ago, maybe 2 years ago now, where this study was published in 18 patients. They had these advanced cancers. They were given immunotherapy. They had MSI high tumors, and the tumors went away. Immunotherapy is a miracle for people that have cancers that it works. In the previous years, we would have to treat people with chemotherapy, radiation treatment, and surgery. And now we have this option. Unfortunately, if you don't have Lynch syndrome, or you're not one of the small percentage of people that has an MSI high tumor, that it was sporadic, which can occur, then the immunotherapy stuff is off the table. So we have to, keep this in mind when we look at patients with Lynch syndrome. We're going to give them immunotherapy rather than give them the traditional 5-FU based chemotherapy, because the 5-FU stuff doesn't work and this stuff works really well. Next slide, please. So a few additional thoughts. We've been talking about genetics. Genetics plays a role in everything, right? So we're talking about things that Kyla can point out in your genetics that might make you at higher risk. There's a whole host of things we don't know. But colon cancer is on the rise in young people without Lynch syndrome and young people without FAP. We don't know why, but it's a true fact that people born in the 90s, so your millennials and younger, are at 2 times the risk of developing colon cancer than people born in the 1950s, and 4 times the risk of developing rectal cancer. This is not a genetic problem. We did not evolve as a species in the last 50 years to suddenly be more at risk for colon or rectal cancer. This is something environmental, obviously, something we eat, something we drink, something in our lifestyle that is causing these cancers to be expressed at a greater rate in this other population, and we don't know exactly why. Next slide, please. So I also want to point out that even though you may not have a genetic risk for cancer, for colon cancer, everybody has a risk for colon cancer, because being present on this earth for a certain period of time allows your body to develop those mutations that we talked about because of exposures. So everyone should get screened at age 45, even if you don't have a genetic risk, even if you don't have a family history. If you have family history, you have to get screened at a younger age than your family member had their cancer or other polyps detected. And anybody with inflammatory bowel disease needs to have their colon screened. And there are some higher risk individuals that we should have a higher index of suspicion on if they develop any symptoms. Black men are the highest risk general population. People who are obese and have a poor diet. And again, that generational deficit or generational risk that I talked about earlier. Next slide. I think we're just about done. So this is again, our diet. I'm going to skip this for the interest of time because I know we're running out of time and I want to get to some questions. Somebody's computer, is that you? Okay, great. So so obesity is playing a risk. Obese patients have about 3 times greater risk of developing colorectal cancer than non-obese patients. So that's a risk factor. Next slide, please. Can you hear me? We're having some technical difficulties, I think. Are you able to advance the slide at this time? Well,
I
I'm
think
gonna
Kyle might
talk.
be having trouble hearing us, Dr.
I-
McCormick.
Can you hear me now? Can you hear me still, Marjorie?
I can hear you. Yes, you're coming across loud and clear. I think Kyla
Excellent.
might be having the.
That's
something's
okay.
grazing on
I
her
don't
end.
need the slides. There were just a couple left. I think
Okay.
that the last couple of slides were for the audience members to understand that it's critically important that you choose where you get your care very carefully. And it's not an advertisement for Allegheny Health Network, although we do happen to do this very well because of Kyla and her team and because of the cancer team that we have caring for our patients. But these are not decisions that are easy to make. This is a very nuanced process on how to decide what patients have these disease process, what have these high risk conditions, what patients have these genetic predispositions, and how they're going to be treated. And you want to go to a place that has a team, that has all of the members of the team available to you and resources to you to help you through that process. We have a great team of geneticists and surgeons and medical oncologists and radiation oncologists and pathologists and radiologists and nurses and nurse navigators and financial counselors, social workers, a whole host of individuals who, for every single one of our cancer patients, is available as a resource for all of us to use each other to make sure that your care is delivered and the decisions that are being made are the cutting edge, the latest and the greatest information for every individual. And I can't express how important that is. Colon and rectal cancer specifically, these are not that common, that a place that doesn't have all of those resources and that isn't doing a high volume is necessarily going to be able to maintain that standard of up-to-date care. So please be careful and choose your provider carefully when you're trying to figure out how to navigate if you have one of these problems or you develop a colon cancer or a rectal cancer. Please be careful and be thoughtful about how you choose, where you get your care. That's all I have. I noticed there were some questions in the Q&A. I did answer one of them because it was up my alley in terms of colon cancer. And some of these are really more specific genetic counseling that I would 100% call on Kyla to answer. I don't know if she's able to do so or not, but that's maybe is she available? Are we good or?
Can you hear me now?
Oh, great. Oh,
yeah.
awesome. Thanks.
Yeah, Kyla, I don't know if you can see the questions. One straightforward question is, do you test using mitochondrial RNA? That was just a very technical question.
Not mitochondrial RNA for oncology genetic testing at this time.
Okay.
There is some mitochondrial testing that's done, but more in a like non-oncology setting right now. Nothing that we know of related to the mitochondrial like DNA, RNA. We do RNA testing though of those genes that we were just talking about. So like the BRCA1 and 2 and the Lynch genes, we can do RNA analysis in addition to DNA analysis, which kind of makes sense. If anyone going back to those biology lectures, your RNA is like converted to the DNA, or the DNA is converted to the RNA. The RNA makes the protein. And the protein is actually what's going out to our body to perform whatever functions it is that we're looking at. So especially with some of those uncertain results, RNA testing of the genes might help clarify the significance of that change because we get a little bit closer to that protein level, which is actually what's out there doing what it needs to do. So we do RNA testing of those genes, but not mitochondrial RNA.
Okay, thank you very much. And I think in the interest of time, there's a couple other questions that are more specific to unique circumstances that I can give the referral number for if folks wish to come in to schedule a consult or something like that. So any other comments you guys would like before I proceed with the closing remarks?
No,
Okay.
I really appreciate Kyla. Again, great job. And we certainly are happy to have such a great genetic team available to us because it makes a big difference. It helps us really, provide that full wraparound service for all of our patients.
Yeah, thank you. I feel like we have a good team in general here. Everyone works together well.
Yeah. So we would like to thank you all for attending our Ahead of Cancer lecture this evening. Please continue to join us monthly ahead of the Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, as well as survivorship. As a reminder, tonight's lecture was recorded. If you're interested in rewatching tonight's lecture, check back on the AHN YouTube channel, what's the YouTube channel / Allegheny Health Network for the full recording in about a week. And this video, as well as other past lectures, are there on the Ahead of Cancer playlist. So you can also listen to previous lectures. If you'd like to schedule an appointment or have questions regarding a potential cancer concern, please call the Hope line at 412-578-4673, 412-578-4673 to schedule an appointment. You may also call our 24-hour Nurse for You line at 412-687-4968. Thank you both for a great presentation, and thanks to all who attended the lecture this evening, and have a wonderful evening.